Just a reminder, the topic is building bridges between harm reduction and treatment for people with substance use disorder. I'm just going to click through SAMHSA disclaimer again. Just reminder to kind of be respectful with language and kind of focusing on people first language. I'm going to rearrange my screen a little here. There we go. And, feel free to post in the chat and use that as a way to kind of have conversation, or use the Zoom feature to raise your hand, or just, feel free to speak up if you have any questions or commenting on discussion questions. And so we'll be focusing on the last two objectives here today, kind of ways to strengthen connections between the harm reduction as an approach, treatment, and other supportive services, and explore how treatment providers are incorporating harm reduction into their work. So one of the things I wanted to start with is I looked for a few graphics. I'm sure in a lot of your work, you've come across different ways of thinking about types of substance use. So I'm going to show a few options here. This one is from Canada, but, really thinking about, different types of substance use. Sometimes this is referred to as a continuum, although that can kind of suggest that there's an inevitable progression along this. And, particularly with polysubstance use, someone might be engaging in experimental use or social use of one substance and harmful use of another substance. So, these, again, you'll get all the slides within the week, I think, of this session, but, just helpful to think about, different types of substance use. And here's a couple more options. I like the kind of drawing on the left, similar overlapping categories, thinking about whether you're calling it experimental or social use, to regular use, to problematic or harmful use, a dependent use. And increasingly seeing kind of prescribed use as an option in these types of graphics and discussions. So someone might be prescribed medications, obviously opioids is something we talk about a lot lately. But thinking about that as something that's maybe different than, social use of recreational or what's known as sort of illicit drugs. And, one thing to think about is sort of, when we talk about bridging harm reduction and treatment, you could argue that all these types of uses could benefit from harm reduction approaches and strategies. Whereas when we're talking about treatment, thinking more about that right end of this graphic here, where there's the red circle of kind of dependence or problematic use. And maybe, 10 or 15 years ago, harm reduction was also thought of something that's kind of maybe more in that category, possibly applying to social or occasional use, but that a lot of the strategies and locations where people would get harm reduction services, we're really thinking more about people with, substance use disorders, or at least regular use. So that's just kind of something to think about as harm reduction becomes something that maybe would be applied to even that experimental use, if you're talking about, young adults and kind of how they're experimenting with substances or using them socially. Any questions on that or comments? Feel free to share in the chat. So we talked a lot last session about kind of harm reduction and various services that fall within kind of the harm reduction category. And just like to ask everybody to think about and kind of post, responses in the chat, kind of, free association here. If you think about treatment specifically for people with substance use disorders, what are the types of things that should be on a menu of treatment options? If we were thinking about creating a graphic. And again, just doesn't have to be comprehensive, but just if you could all kind of type something in the chat, it'd be great to sort of see a range of responses to what you would see or have thought of as being on that menu of treatment options. Give everyone a minute to type something. Marla writes psychoeducation. Thank you. Adding relapse prevention. So counseling, testing, pro-social activities, this idea of community support. Hi, Penelope. To answer that I think I'm arranging a lot of things on my screen, so I lose some of the things. So this is sort of the size. I apologize if that's a little small. Housing assistance, so getting more specifics into CBT, cognitive behavioral therapy, peer support, psychoeducation, employment assistance. So, those things that are, might be thought of as wraparound services, harm reduction, medications for addiction treatment, support networks, DBT, dialectical behavioral therapy, support for sober activities, mental health support, trauma-informed care, and kind of addressing adverse childhood experiences known as ACEs, educational programs, 12-step or mutual aid. So there's a lot of things there, but interestingly, and thank you all for posting, I didn't see a lot of great graphics that looked at this menu, this kind of menu. So here's my attempt to kind of create one. And this leaves harm reduction partly for space, sort of in a separate category, particularly since we talked a lot about that last week, but you could have sort of a fourth box here. But kind of trying to think about it in these different categories, like what broadly would fall under counseling and mental health care, and you could arrange these in different ways. So thinking about group therapy, individual and family therapy, case management, peer support, mutual aid, all those kind of personal connections, whether it's provided via kind of clinicians or, mutual aid and peers, kind of all falling under that kind of broad counseling and mental health care. And then I see Joseph adding spiritual counseling. Yeah, that's a really important part, particularly for people, who seek out and kind of benefit from faith-based services and just kind of spirituality more broadly. Medications and medical care we have in the middle there. So, starting with kind of detox and withdrawal services to methadone, buprenorphine, I've listed Suboxone, there's other variations now, naltrexone, naloxone, so psychiatric medications, HIV, Hep C testing and treatment, wound care, other medical and dental care. So these are kind of things I broadly put under that kind of medical services and medications. And then on the right, wraparound services. So legal aid, housing help, employment, educational programs, and benefits navigation, so things like helping people get signed up for, any public assistance or health insurance or those types of benefits, housing assistance too. So, this is a partial list, partly kind of trying to fit it on screen, but I think interesting, to kind of really think about what if we did have sort of a consensus on what a menu is and that people had kind of choice and a selection of services to choose from. Any thoughts on what might be missing here or ways of arranging this? And if there's any graphics you've ever seen, feel free to add those in the chat. And just kind of as a contrast, this is, one of the things that was kind of noteworthy to me when I was looking for something like a menu is that, when we talk about types of treatment, we often focus a bit more on the location it's offered. So, sometimes when I've asked this questions, people come back with like outpatient or residential and inpatient or, a doctor's office, primary care, which is really about the place someone is getting services as opposed to the type of services. Important to sort of have data about that. This is from the National Survey on Drug Use and Health, and these are the categories they use in that survey. And you can kind of see that even though sometimes sort of popular perceptions about rehabilitation tend to focus on inpatient or residential care, really the vast majority of people do get care through outpatient services. So, again, these are all slides you'll receive, but just kind of thought that was interesting that sometimes we really think about location as opposed to what's on the menu. So this is kind of in that Penelope's asking, does virtual services here include counselors in private practice? I'm assuming it does if that's happening on Zoom. But that's not something I've looked into as a category, and I wonder if that's something that's kind of been added in recent years, particularly during the pandemic. That's a good question. So, we've all heard about this kind of idea of the treatment gap, thinking about people with substance use disorders. So, we talked last week about how 10% of people with substance use disorders receive treatment. That's kind of typically what comes up in surveys. And again, these national surveys do miss some populations, including people who are incarcerated. And a lot of the surveys were disrupted during the pandemic. So, but that's sort of consistently, people here, only 10% of those with SUDs actually receive treatment. And it's important to acknowledge that many people with drug and alcohol problems achieve long-term stable recovery without formal treatment. So, not everybody seeks out or necessarily needs treatment. And there are debates about what's considered treatment. Some people might say that, certain services that fall under the category of harm reduction aren't necessarily treatment, or that mutual aid isn't necessarily treatment. So I don't know that there's a real consensus on that, but, I'm kind of approaching it broadly and thinking about treatment, almost as an equivalent of care. And that many people need support beyond treatment in order to recover from a substance use disorder. So, thinking about those wraparound services, that you could get the best treatment available for a long duration, but still, if you're facing challenges, with housing, legal situations, employment, kind of reconnecting with family and other important personal relationships, those things might not traditionally be considered treatment, but are all very important for people. Any thoughts or comments? Vanessa?
Good afternoon.
Hi.
Hi. Well, I'm backing up what it says about the services, and when we say wraparound services, most of us, we know about that, but it's not saying so much as to support peer recovery and recovery specialist and so forth, because from my experience, so many people will say that they've relapsed because they were bored.
I think that doesn't get talked about enough.
Yeah.
I think that boredom. I had the peer over here on the left.
Right, but the thing is that what I just need to say that regardless of whatever services they may be receiving, they all will oftentimes say that they relapse because they were bored. So that's why I believe that having some type of center with activities and so forth that people can attend, a support place, would be, really beneficial. I know a lot of people that will spend their day just trying to make it from like going to a 7:45 AA or NA meeting in the morning, and it's really trying to hang in there until 12. Their whole life is dependent on just sustaining themselves until they can get to another meeting so that they can have that peer support. So I believe that having a place where, like a recovery center or something that people can go to, like a day program for people that have mental health diagnoses, and receive this support to fill those gaps, fill the gaps in time, from when they go to a therapist or their doctor or whatever it is that they're doing.
Yeah, and those are sometimes there's been a little bit more focus on that need, for kind of what are sometimes called recovery community organizations, or RCOs, and kind of increased funding. It seems in the places I've seen them tend to be kind of more smaller communities than big cities, but that's just somewhat anecdotal, as if it's easier to find, with real estate being kind of a barrier. But I think it's a really important point, is that, when you think of someone who's spending a lot of time obtaining and using substances, then when you're kind of moving away from that as the focus of your day, that, thinking about what are you going to replace that time with, so that purpose or activity, that's that's something I think could be sort of thought about in these, wraparound services is, for some people that might be moving back into an educational pathway or employment. But sometimes there's that period in between where, how are you going to fill your day and sort of what are the social networks that people can go to. So thank you for that, Vanessa. Just going back, whoops. So, thinking about that treatment gap, I think one thing that really struck me is that, we tend to be in a kind of polarized, era where there's a lot of binaries, right? So, on the far side, you can talk about mandating or requiring treatment and a lot of reasons why people might be opposed to that, and then on the other side, waiting for someone to be ready for treatment. So I was kind of thinking about, what's in between mandating and waiting, and kind of words like nudging or motivating, encouraging, facilitating or incentivizing, and really, I think that's sort of the motivation for this kind of workshop, and this topic is sort of what can be done in that middle to kind of help people beyond just waiting for them to be ready or kind of mandating. So thinking about that word nudge, this is something anybody kind of in public health has certainly heard. And, even if that as a concept is less familiar, these are things that, happen all the time, whether they're calorie counts on menus, to kind of make people aware of what they're ordering, particularly, in areas where that's required on some restaurant menus or fast food chains, cigarette taxes, smoking bans, vaccine clinics, motorcycle helmet laws, soda size restrictions, these are all kind of forms that have happened in public health of kind of nudging. And, this book by Cass Sunstein is kind of addressing this and describes nudges as initiatives that maintain freedom of choice while also steering people's decisions in the right direction as judged by people themselves. So, you could maybe say, oh, is the right direction, that's subjective, and that parenthetical sort of adds, what people are judging. But, there's a lot of reasons for nudging, that people don't always make choices in their best interests. We all have difficulty thinking about our future selves when we make decisions. Sometimes we lack information about options, or we're influenced by marketing or other interests, and, just the harm to others that some behaviors cause. So, that's sort of a broad way of kind of thinking about this middle ground on nudging. Yeah, TV ads. And this I came across was an essay that kind of breaks that down a little bit more. And there's a link there, the context was public health, not specific to substance use. But, if you think about these questions, who do we nudge? You're kind of making choices. Is it all people who are misusing substances, or focusing on people with addictions or substance use disorders? When is the best time to nudge? There's initiatives that are kind of trying to reach people after an overdose. Sometimes that happens before an arrest, or when picking up syringes or supplies. What is the thing that we're trying to nudge? Is that changing substance use behaviors, or specifically considering treatment? Where's a good place to nudge, or places to nudge? Some things happen in courtrooms, could be in a doctor or counselor's office, a syringe service program. How do we nudge? As Vanessa mentioned, utilizing peer support, by removing the barriers that make it difficult for people to access treatment and services. Do you nudge by making treatment more appealing to people? And then what is sort of the reason for nudging? Is that about public health goals like reducing overdose deaths or reducing harm, or is it improving someone's individual health? And these are just kind of questions to put out there, and kind of a way to think about, framing this. So not necessarily like concrete answers here. Any thoughts about this or comments? Maria writes, I like the way media promotes Sober January and other types of reframing. Yeah, so that's, media can participate absolutely in nudging, both in a positive or negative direction. So thinking about media more broadly, entertainment media, the films and TV shows we watch and music people listen to, kind of can frame that. So if we're kind of talking about this idea of kind of motivating, incentivizing, or facilitating or nudging treatment participation, what are sort of some of the specific tools and interventions that you've either heard about or kind of come up in your work that kind of fall into this category of helping people or motivating them to access treatment? So Lisa, that's actually a good answer to this. I have found street outreach conducted by peers is the best engagement strategy. However, we still wait for their readiness. Penelope writes documentaries showing people struggling and then getting empowering help. Helping someone identify consequences in one-on-one therapy. Thank you, Marla. Any other things come to mind? We had a It Takes a Village documentary on recently. Absolutely, kind of thinking about it as not just, it's on the individual, but, kind of the network surrounding that person and the community and sort of the wider services available. So these are a few things that kind of have come up, in terms of, more practical tools to some degree, kind of all things that are evidence-based and that have been researched. Many of you have probably done workshops on motivational interviewing, a collaborative conversational approach to strengthen a person's own motivation and commitment to change. So, there's some links here, resources, and a lot of training opportunities. If you haven't participated in that, it's really a great tool just even to know about and use in your own life, how to get someone to change behaviors or think about changing behaviors by identifying what might motivate them. Contingency management, so often used for people with stimulant use disorders. So that's a program that uses positive reinforcement to reward behavior change. So often using vouchers or private prizes. There's a link here that describes that in more detail, but there are kind of trials happening specifically in California, to kind of be able to, do this approach on a wider scale, using kind of small monetary compensation and see, particularly for people with stimulant use disorders, what the effects are there. There have been kind of some barriers in terms of not being able to actually, give monetary incentives due to some federal and state regulations. So there's definitely more of a focus on that lately. Peer support. We've talked about, people with lived experience with SUDs, often incarceration and mental health disorders, offering guidance and support to help others achieve their goals. And then screening, brief intervention, and referral to treatment. So that's kind of a practice, often, not often, but typically found in kind of primary care or emergency rooms or other healthcare settings, where kind of this is a brief intervention to kind of identify and encourage people to access treatment for substance use. Any questions on any of these? Provide written resource information to people, Vanessa writes. I think that's incredibly helpful. And, the web makes that a lot easier as well to have directories of things, services available in a community or a state. But just having that, information written out so someone doesn't have to seek it out themselves.
Yeah, because, I know there's a lot of people that are living on the streets. Mm-hmm. And many of them have the concern, have expressed to me that they have the concern of autonomy. And they're afraid to go to our local hospital emergency room for help, mm-hmm. because of the way they're often judged, mm-hmm. and treated. So being able to compile information with that in mind, mm-hmm. I believe is more like compassionate treatment.
Mm-hmm. And kind of vetted providers or trusted providers. So when
correct.
handing someone that list or making a recommendation, it's somewhere that or hopefully, they'll be treated with dignity and respect. Penelope asks, I would love to hear more about street outreach. Do people work from a script and then respond naturally to unique individuals too? Does anyone want to answer that? I can chime in, but if someone's kind of doing that
I've
kind
actually do that,
of,
and that is to begin by establishing relationships, because it's kind of like a level of building up, and just letting, well, most of the people know already my position, but they know that if you let them know, hey, I'm in recovery, or what you're about, what you're there for. And I just, I'm not judging you. I just would like to let you know that people care about you. Because when they're in the midst of their addiction, oftentimes they feel isolated, judged, unworthy, full of all those things that they talk about in the program. And then following up, hey, how you doing? Just being there. They know that you've already established the fact that I have these resources available if you would like it. And then just like maybe the next week going in, hey, how you doing today? Just thought I'd check in, They know that they're on a consistent basis. You can offer your phone number or a number they can call, just to talk if they want to talk, or to ask for help. Asking for help is very difficult for people that are in their midst of their addiction. So that's why I believe personally that it's good to establish that and follow up with that connection. But you can offer a phone number that they can call if they want, or give them your establish a Facebook account, because a lot of people, they would feel more comfortable to send a text message or something, things like that.
Thank you, Vanessa.
And then offer to take them to treatment, detox, taking a lot of people.
So I think from what, I've experienced different organizations, it can kind of depend on the resources, right? So there's some, street outreach that kind of might be paired with a mobile unit, or just, a van that's parked in a certain area, a parking lot on a regular basis, or, near a park. So that consistency where people kind of know that on Mondays it's in this one place, and on Wednesdays or Fridays it's in a different place. So, that word of mouth spreads, and, then there is some kind of just engaging people walking around. Then followed programs, New Jersey Harm Reduction Coalition, kind of literally taking kind of a hand-pulled cart of supplies out in parts of New Jersey. And, I think people sort of learn what works in their community in terms of responding to people, so, there might be specific training, but I think, not necessarily a script, as you'd asked, but, kind of best practices that each organization learns. And then, kind of responding to an individual situation, where if there's a person that a group of people is used to seeing or hearing about, and that person is no longer kind of showing up, or, the kind of knowing where to go to find that person or who to ask. But I think, there are a lot of the teams that do this sort of street outreach do receive a lot of training in kind of how to engage people and talk to people, and kind of have that respect and let them kind of take the lead. Autumn asks, any quick tips on how to help my case managers document motivational interviewing? I feel like I've talked about it and taught it so much, but sometimes it still does not stick. I think probably, these organizations like the Addiction Technology Transfer Center have that technical assistance who can kind of follow up with kind of more specifics on that. But I think that falls under that category of implementation, that you can have this greatest training or a research study that shows something, but how do you implement it in practice, and kind of not just learn about it once, but keep learning about it as you use it and have questions. So, I've made a note of that question, Autumn, so I'll make sure to pass that along. Carmen's mentioning kind of inpatient treatment discharge plans that involves follow-up with the patient. So I think that's another bridge from treatment to kind of support in the community, that, you could do a whole other workshop on. Lisa says street outreach, you just keep showing up. And Gary's mentioning the stages of change, that it's in that pre-contemplative stage as we're thinking about changing, that it's about engaging with that individual and kind of building that relationship, about their agenda, not ours. Donald Powell has a hand up. A question, or is there something we want to?
Yeah, I just wanted to mention in terms of the peer stuff, one of the things that I think we do really well at Exponents, which is located in downtown New York City, particularly we were requested recently to engage folks in a couple of encampments. And so one of the things we do, you have to kind of meet people where they are. So yes, we have crack pipes and crystal meth pipes and all of that stuff, but we also go out with socks, and we go out with feminine hygiene napkins, and we go out with stuff that people need, that isn't just associated with their drug use. So they get the fact that you value me, you see me as a person, my hygiene, you assume that my hygiene is important to me. And I think those are critical steps into really developing rapport with people.
Yeah, those kinds of things too, whether it's codes, often those are paired with sometimes, with street outreach and, teams of nurse practitioners or medical providers who are also there to kind of do basic wound care and potentially prescribe antibiotics or link people to additional services. Gary?
Yeah, when I talk about engaging folks where they're at, and it's not about our agenda. I've kept it on like really low threshold healthcare and things like that, the person's needs, like Donald was just talking about, like the pipes and the syringes and the Narcan. Those are just like hooks to open up conversations, right? And within these conversations, that's where the change starts. When a person feels they can talk and they can communicate with you, they may start asking questions. And it's really tough with folks who are in pre-contemplative stages of change. Some of them don't want to stop using drugs. Some of them, recovery is not on their agenda, nor do they want it on their agenda. But I feel the more over the years, the more we've kept folks alive, the more they want to change. And if they just change that one thing of taking care of their wounds, guess what? It's a next step after that. And what's it going to be? I don't know, because you know what? It's not my agenda. Would I like to see them all follow the yellow brick road of recovery? Sure. But that's my agenda. It's not theirs. So it's really, really building a relationship, engagement, building a relationship, and maintaining that relationship. And sometimes it's over the period of years and years. I mean, I've worked with folks for 20 years, more than 20 years, that they remain in their drug use. Have they gotten better? Maybe not in other folks' terms of recovery, but some folks have come to realize that they need to change their drug use. Some folks realize that they have to go to a doctor. And like it was said earlier, they're not, like the medical profession hasn't been really receptive to people walking into their emergency room who have opioid use or drug use disorders or anything like that. Like, and they are talked down to, it's just been changing in the last several years where docs, I know the work that we've done over the last 35 years or so, it's now, I'm working with a medical center where we introduce folks to street doctors, to doctors that will come out into the street. And if you nudge, if you want to call it, they're nudged into like maybe coming for an appointment. It doesn't happen overnight. It takes a lot of energy and perseverance for both, like the person that you're working with and yourself to like just stick and stay and provide that person with what they need. Peanut butter and jelly sandwich, like, you know what, a clean drug supply would be wonderful, but we're so far away from that, in this country. We're still in archaic times as far as our drug policy goes. So, there's a lot of things that need to be worked on. And unfortunately, drug policy is going to take years and decades and a lot of time, and most of the time when we're dealing with like HIV or overdose, we don't have the time. People are going to die. So just trying to keep folks alive and feed them with what they need to keep themselves alive is a success, is a big, big step toward wherever they're going, either recovery, church, family, building bridges back with their loved ones, because they've all lost connection with their family, their friends, and their community. And now, they have no connection. So I think it's really important. But we try to throw recovery coaches at folks that want to guide them into recovery and things like that. There's a step that we need to do before that. We talk about peers, with lived experience. We need to talk more about peers with living experience, because guess what? They're the messenger. We just started a program through the study I'm working on where we had peers distributing naloxone. Okay. Now it wasn't sustained. The naloxone distribution in that program has gone down 50% because it wasn't sustained. And that was using peers that were still using, and they were distributing naloxone to their peers, and they're using network. So that's all gone now, and it's just that, what, we don't throw resources that way. It's sad, but people don't want to give money to drug users. And I know over the years I've gotten information from drug users that I've been able to help and participate in writing grants that have brought in tons of money. But again, it's
yeah, I have seen a lot of examples of people with living experience, as you say, kind of involved in the distribution. So sometimes that's referred to as secondary distribution. Other times they're hired by harm reduction groups as peers. And then just really, thinking about street medicine as part of street outreach. So a lot of the models kind of relying on medical residents, often in conjunction with kind of, whether it's a supervising doctor or nurse practitioner, I think starting to see more of those collaborations and partnerships.
And have their voice at that table, because I know when we started to do HIV work in the 80s, it was guess what? Having people that were HIV positive sitting at the table. You look around coalition meetings now, you don't see people who are actively using. You don't see people that go into the drug users union to recruit folks to come to their coalition, and they're sitting in the same community, but they're not invited to the table. So they don't have a voice. So we're sitting around a big coalition meeting talking about what's best to do for them. Not for us, not for the people. They're not in our rooms, so they're not part of the solution, and we don't allow them to be part of the solution.
Thank you, Gary. I wanted to get to one question here because I thought this was a good point. Donald had written in the chat, what about individuals who struggle with reading and comprehending because they would do better with audio recording over written information alone? So, I think a lot of the outreach, in the context of street outreach, really is about these conversations. But I think that's a good point of, if you're distributing flyers, that, that should be taken into account, in terms of reading comprehension and level, and also is someone going to hang on to that? But my sense from, the street outreach that I participated in or followed along is that a lot of this is really about the kind of conversations and that people aren't just relying. It's great to have lists of information, but it's more about that kind of walking someone to that service, sometimes called a warm handoff there.
I just want to add, I'm sure that Gary can give you more information about the program that goes in there behind Fenway Park. The doctors and the nurses, they go in, they do needle exchanges, that are offering treatment and all that, like he was speaking about, and giving clothing, all kinds of things. It's just wonderful.
And Penelope had asked, do people ever find trying to reach people with addiction challenges push you away as a do-gooder, or you don't know what you're talking about? How do you cope with that? Maybe practical stuff like socks, hygiene products, et cetera, help start a connection. Praise to all doing such work. I mean, I think that's sort of the idea behind having, you know, those resources, you know, whether it's warm socks, condoms, supplies, wound care kits, other things people don't think of, deodorant, that kind of thing, that it is about that connection and building that connection over time. You know, Boston Healthcare for the Homeless, yeah, that was the organization I was thinking of when you mentioned Boston there. Maybe just a warm meal too, yeah. So kind of, you know, going back to the thinking about kind of facilitating access to services, or, you know, by removing barriers to care, you know, this is kind of a partial list, but, you know, increasingly efforts to facilitate treatment on demand, so that when someone does express an interest or is ready, that it's not a matter of weeks before they can get connected to services, due to different bureaucratic hurdles or just the availability, you know, so that might be navigating insurance coverage, payment hurdles, you know, helping with transportation to services is really critical. You know, that's something that particularly in kind of rural communities, but even in some urban and suburban communities, you know, if people can't get to these appointments or get to where services are offered, that's a huge barrier. So I've seen a lot of areas where recovery coaches or kind of peer support advocates, often doing some similar role, different names, but, you know, are actually providing rides or bringing services to people. Offering person-centered, culturally sensitive care, you know, more of an emphasis on kind of thinking about that as opposed to one size fits all, or assuming that, you know, everybody's going to respond to the same type of service. And then reducing regulatory hurdles that limit treatment access. So seeing a little more focus on that with, you know, particularly medications for opioid use disorder, and, you know, kind of making, you know, proposals to make methadone more accessible, or buprenorphine and other versions of those medications more accessible to people. So this is something kind of thinking about this idea specifically of bridging kind of, you know, syringe service programs, participants in treatment. This was a statistic I'd kind of seen mentioned a lot, you know, in media coverage and in research, you know, that I kind of started looking into, that, you know, new users of syringe service programs are 5 times more likely to enter drug treatment and about 3 times more likely to stop using drugs than those who don't use the programs. So this comes from a CDC summary of the information on the safety and effectiveness of syringe service programs. And here, you know, this is a statistic or a study that was kind of done in Seattle. I'm going to show a little bit more about it. And, you know, they really looked at people who had either never used the exchange, were former users, currently use it, and new users. And, you know, found that, you know, they were specifically focusing on injection drug users in Seattle and their retention and methadone treatment. And people who had formerly been users of the exchange were more likely than people who had never used the exchange to report a reduction in injection or to stop injecting altogether and to remain in drug treatment. And specifically, new users were 5 times more likely to enter drug treatment than people who'd never used the exchange. So this was done in kind of the late 1990s. The study came out in 2000, but there hasn't really been much kind of additional research since that time. There's a few other studies out there, but, you know, looking at kind of a specific population here. And this is one done by some researchers, Noah Kravchuk and her colleagues at NYU and some related institutions, looking at kind of intersecting substance use treatment and harm reduction services, and really exploring the service needs of a community-based sample of people who use drugs. You know, so one of the things they've kind of concluded here, and this is a link to what should be a publicly available version of the study, is that, you know, finding that in many ways existing programs are not meeting the service needs of people who use drugs. you know, particularly with, you know, programs either doing treatment or a harm reduction approach, but that the treatment programs were not necessarily, you know, and specifically medication, were not necessarily providing information or tools about harm reduction, and then vice versa, that, you know, that people in the harm reduction settings were not necessarily getting that linkage or information about treatment. So I kind of was curious about, you know, whether, you know, much data is being collected about this. And there are a lot of barriers. These are, you know, programs that are often kind of struggling for funding. And, you know, in some states like Michigan, the state is collected. So this looks at kind of the end of 2022 and looking at, you know, the number of treatment referrals that were made there. So they kind of talk about direct contacts and indirect contacts. So those are kind of that secondary distribution of syringes and supplies I was talking about. And then, you know, about 1,400 treatment referrals in that last quarter of 2022. You know, and again, many of these places don't have the resources to do this type of data collection. It is mandated in some states. Or really to have the staff and the infrastructure to provide those connections to care. This is another example. Utah data, you know, they require referrals to treatment for every encounter. There's 7 syringe providers or syringe service programs in Utah. And, you know, you can kind of see that what they call an active referral is pretty low, you know, and that the types of referrals are either written or verbal. So, you know, really thinking about, you know, is that the best approach? Like to just have that a state requirement that someone has to mention treatment every time you're having an encounter, or, you know, creating a system where, you know, or a process that this is done kind of more organically at appropriate times, you know, back to that kind of when and who and how and where to nudge. So I wanted to kind of be specific about a couple examples that I've been able to see and kind of, you know, learn more about with that kind of offering treatment directly at an SSP or having, you know, kind of more robust connections to care here. So this is Prevention Point in Philadelphia, and they've been around for decades now, and, you know, known more for the syringe service program, but really do a lot of case management and, you know, other types of care and treatment as well. So, you know, medical care, overdose prevention, education, medication-assisted treatment, and naloxone distribution. So this is all from their website. And they also offer housing, meals, and mail services for people facing housing instability. So they now provide mail services and then, you know, basically offering an address to people who otherwise wouldn't have a consistent address to about 5,000 people now. So someone might be there to pick up mail or first engage with them because of that service, and then be in, you know, the drop-in center in line to pick up mail and hear about, you know, this program they have called STEP, which is the Stabilization, Treatment, and Engagement Program, a medication-assisted recovery program that offers participants the options for treatment for opioid use disorder. So the most commonly prescribed medications they use are either the naltrexone injections or really mostly buprenorphine these days. And, you know, they also do referrals to methadone treatment, inpatient, and other treatment options. So there's a lot of entry points someone might have to this program. And, you know, they're offering kind of different, you know, with buprenorphine, it can be a monthly injection or coming in for the oral several times a week. But they've really seen an uptake in this, you know, particularly since kind of coming out of the pandemic. They had, as of June 2022, about 400 people participating in this program. So, you know, people in the program work with a care manager, they're paired with a recovery specialist, and attend, you know, behavioral and mental health appointments either on site or, you know, at other providers. But they refer to themselves, and this is probably something that many of you have heard, as sort of a low barrier or low threshold program, that they, you know, people don't have to have ID, they don't require insurance at intake, they have transportation support available. And, a key thing about this program is that if someone relapses or, is using other substances, there's no judgment, so really kind of focusing on this, not kicking someone out or excluding them from care, but, kind of trying to provide that support and, treatment through this service. Any questions about Prevention Point or this particular program? So another example, a little more recent, is the RED project in Grand Rapids, Michigan. So this was something they had kind of they have a pretty robust, presence on Instagram and, flyers that they kind of created. They'd wanted to do this program for Suboxone specifically to incorporate into their mobile unit services. So really thinking of a way to bring medications to other counties near Grand Rapids where people don't have access to as many providers as are in Grand Rapids. So they began it at their office sort of as a pilot program to kind of get it up and running and to see, how it worked. And really were surprised that despite the fact that there's so many providers in Grand Rapids, just being able to do this initiation on site really made a difference to their participants. So someone might not have gone and, gotten buprenorphine from a provider, even if they were told, here's a list of providers. But, with this program, someone can walk in, they can be picking up syringes and express an interest in it. And they've partnered with a trusted provider, Corewell Health, so that, providers are available. And there's a recovery, they call it a recovery coach, who are the peer support, people with lived experience within the organization. And, this is someone, she's someone who had used medication herself and was really involved in kind of setting up the program and choosing this provider. And, have funding from a state opioid response grant. So always important to kind of figure out what are the pathways to fund these types of programs. And, again, people don't need an appointment for an initial visit, assuming there is availability. That first visit is conducted via telehealth from the RED Project's office. The provider then will help the person navigate insurance coverage. And, because they're going to be taking this on the mobile unit, that was really important them to be using oral swabs for toxicology testing. So to sort of gauge what substances and the level of, buprenorphine. And again, with this program, abstinence is not required for treatment. So, what this recovery coach told me, our job is just to bridge that gap for the first appointment. It's the warmest of warm handoffs, and just talked about her experience of thinking about treatment and how many times she thought about it and just getting over that hurdle of kind of making it happen. So, that idea of the warmest of warm handoffs, making it really easy for somebody. Any questions about that program? Yeah, the question about CleanWorks, that's just what they call their syringe service program. There is a movement to kind of move away from that, but this is referring to kind of the syringes, but that's the name that they use. So these are, we can focus a lot on syringe service programs, but thinking about other places where harm reduction can be a bridge to treatment. So increasingly, there's some kind of, one example is law enforcement diversion and deflection initiatives. So, this has been done a lot specifically in Ohio, where they're called quick response teams, responding to people who have overdosed. So a team involving some combination of a police officer, firefighter, paramedic, and a peer support or treatment professional might visit people who have overdosed and kind of offer help accessing treatment or other services. This link you'll get and kind of describes that and describes sort of the philosophy of deflection and as opposed to diversion, which is deflection is kind of thought of as, referring someone to treatment before an arrest happens. So, someone isn't going to end up with that criminal record. And another venue, increasingly kind of hospital emergency departments or EMS services. So, California Bridge program out there is a really robust program that helps hospitals in California initiate medications for opioid use disorder and connect them to treatment services in the community. So, setting up initiatives and ways, and there's a link with more about that and kind of how that works in California to offer people medications, either while they're in an emergency department or sometimes on EMS kind of units out in the community. So yeah, Donald has kind of posted emergency rooms, student union shelters. So, there's a lot of opportunities to kind of bring this to, schools, jails and prisons, mobile treatment services, and kind of other locations, thinking about, where can that kind of harm reduction pathway then offer engagement with treatment services. NYC has the Be Heard program. Yeah, I've heard about that with the EMS, PD police department, I think, and a social worker usually. So, there's different combinations in different places, but, sometimes they're called post-overdose response teams or PORT. Other times it's been called naloxone plus, so that you're not just giving naloxone, the medication to reverse an opioid overdose, but then doing something beyond that, with a follow-up visit. Yeah, what other words can we use for syringes? Maybe new. Yeah, often new is used, or just syringes, sterile sometimes. Any questions or comments? So kind of thinking in, how then can treatment providers incorporate principles of harm reduction into their services? So if you want to use the chat or raise your hand to comment, what are some ways that then treatment providers can kind of be taking more of a harm reduction approach with the services, whether that's residential or outpatient, or treatment services in other settings? Either things that have come up in the work that you do or that you've heard about or things should be happening. How can treatment take a more harm reduction approach? Any thoughts on that? Feel free to use the chat. Not make abstinence a requirement. Thank you, Marla. That's a big one. Focusing on what the person wants to see different in their life. Try less is better slogans or such. Yeah, sometimes thinking about changing how someone is using substances. Respond differently to relapse. Insurance companies should not stop payment for treatment. Yeah, that's a big one. Engagement and respect. Not have the threats, Karen writes, how those are handled. Yeah, not seeing returning to use as a failure of treatment. Great. So I'm just gonna, some of these have been mentioned, but this is kind of an overall harm reduction principles for healthcare settings that I came across that I thought really encapsulated a lot of ways of kind of thinking about this more broadly. So the first one being humanism. So really that idea of respect and dignity, that has been absent from treatment in some settings historically, where it's been more about punishment. So really taking that idea of caring for and respecting patients. Pragmatism, so supporting a range of goals. You could probably call that another word, but not just abstinence or perfection. Individualism, assessing a patient's needs and strengths and discussing a menu of intervention options, right? So, thinking about that idea of presenting choices to people and having conversations about what appeals to them, what they want to try, and what makes sense based on their needs and strengths. That kind of ties into this idea of autonomy. Patients make their own choices about medications and treatment options. Incrementalism, recognizing any positive change as a step toward improved health. Sometimes this can be referred to as kind of gradualism. Accountability without termination. So patients are responsible for their choices, but not fired from care. So that's one that we've talked about here. So that link kind of has that whole article about that, you know, you'll be able to download once you get the slides. And, you know, kind of an important one, and I haven't been able to find any surveys or statistics that are kind of capturing how many treatment programs are, you know, doing overdose education and offering naloxone. But, you know, this is an example of, you know, here we have the New Jersey Harm Reduction Coalition that has partnered with a range of groups, including inpatient treatment programs, to kind of provide naloxone and do training into their services. So in addition to kind of doing the work that they do in harm reduction, they have these kind of partnerships. And, you know, this was a site that I had talked about, you know, again, asking that question about where to find fentanyl test strips. I'm going to put a couple things. So Next Distro kind of is a great resource to not only find out, you know, where you can get naloxone, but if you, putting this in the link, if you go to their state finder, you know, you can choose your state, and then there are a lot of different resources listed in each state. So, you know, where to find syringe service providers, often contact information for the local health department. You know, if the state has a, you know, one of a treatment finder link, you know, they list those. So, you know, different things come up in different states, but it's a really great resource to kind of know about and recommend, because they keep it pretty well updated, certainly to where to find naloxone, you know, whether that's through a harm reduction, a public health program, libraries, or, you know, other community organizations. And just kind of as an example here, if you kind of collect, for those of you in New York, click on that link, you know, that'll take you to the resources they list for New York State. And, you know, this idea of adopting a more humane approach to toxicology testing. So that's partly that shift in language of, you know, not focusing on whether or not someone's test was quote unquote clean or dirty, but, you know, talking about, you know, using other language like a positive test. And not using it in a punitive way. So these are quotes from, you know, treatment providers saying, you know, we don't discharge patients for a positive test. And another one, you know, from someone who works at a Hudson Valley therapeutic community, we don't go into the bathroom with them. We give them the cup and they go into the bathroom. You know, that's been a huge shift, not having them be observed. It's part of harm reduction, also recognizing that this is a trauma-informed facility. We're also moving towards the swabs. So the swabs are what I had talked about, you know, with the RED project in Grand Rapids, and, you know, making that easier on a mobile unit, you know, to be able to do the oral testing as opposed to a urine test, which would obviously be very challenging on a mobile unit, but increasingly more places are kind of looking into that as an option. And, you know, not requiring abstinence in order to receive treatment. So, you know, talked about some of the programs, you know, specifically at Prevention Point and the RED project. But, you know, this is again, the methadone provider in New York City. Abstinence is not the goal that is pushed. Oftentimes, motivational interviewing is used to work with patients to set their goals and develop treatment plans. And in the Hudson Valley therapeutic community, 25 years ago, if you used in treatment, you were dropped that day. Now what we say is if you use, just be honest and we'll assist you. We view it as a treatment issue that needs to be addressed. So that's a big change. Any thoughts on, you know, that and any shifts that you're seeing as far as kind of this idea of how to handle, you know, ranges of goals and not necessarily requiring abstinence? Carmen writes in the chat, the old adage, relapse is part of recovery, you know, and certainly something that happens not just with substance use disorders, but other kind of health conditions that people are trying to change around behavior. Are you seeing shifts in sort of the approaches to abstinence in the areas where you work? Feel free to answer that in the chat. People become traumatized by relapse. So there's this amazing people are shunned in AA and NA. Yeah, so that can really vary depending on, you know, the meeting. But there is kind of this history of, treating return to use as something that's kind of a failure and something that has to be punished. And, this is maybe shifting more slowly, but really kind of trying to see that as a way to re-engage someone in the services that are being offered, or to, with medications, particularly for opioid use disorder, kind of starting with opioid use disorder and then not removing someone or denying them that treatment if they're using other substances. And this kind of idea of punishment here, so avoiding practices that humiliate and punish participants. So this was from an essay written for Salon by someone who had been through a program, and kind of talks about, particularly as a Black man, the rhetoric and heavy policing used within rehab has proved problematic for many Blacks. In rehab, small relapses can send you to jail or increase your stay at an institution or be met with police violence. So, there's kind of been this overlap, not kind of, there has been this overlap between, the legal system and, mandated treatment in some settings, and really kind of programs that were set up with kind of more of these punishing approaches that, particularly for people who, are mandated to treatment or because of a court case or involvement, that threat of what's going to happen to you in the criminal legal system because of any infraction, regardless of whether it involves substance. It can be, overlapping with that system of the criminal justice system. And this was an interesting article, the link is there too, that you can follow up with, but really kind of talking about unequal access to treatment. And you kind of look at that, along racial or ethnic groups, gender, whether treatment is responsive to, trans individuals or, a range of people from different demographics, starting to not look at treatment as one size fits all, but, are programs providing this care that's kind of tailored to people with different needs? Any thoughts on that? And, kind of this idea of kind of within a setting, if there is a movement away from kind of this punitive approach in the places where you work or have heard about? Let's see a couple of things in the, thank you, Penelope. I've seen that site, Stop the Deaths. Different comment there on naloxone. Feel free to add anything to the chat. So this is sort of, from an essay thinking about recovery-oriented harm reduction, as an approach to treatment. So this is an essay by Jason Schwartz. He does a blog there. You can kind of see the whole series and other things that he and other contributors write there. He's worked in addiction treatment in Michigan and himself as a person with lived experience. And, kind of pulled together some different thoughts that have been floating around about this kind of concept of recovery-oriented harm reduction, as a way to address the historical failings of both abstinence-oriented treatment and harm reduction services, recognizing that addiction harms individuals, families, and communities, and is committed to improving the well-being of all people with addictions and believing that recovery is possible for anyone, and emphasizes client choice, not coercion, respects voluntary engagement with services, and supports incremental and radical change. So embraces partial and serial recovery, but seeks to be a bridge to full recovery. So a lot of what that's the context of that is sort of, offering hope and kind of the belief that anything is possible for anyone, regardless of their circumstances. So that's a link to the full essay that you can read, but, just kind of wanted to share that. Any thoughts on these or sort of other ways that, treatment can embrace kind of a more of a harm reduction approach? There's a few more messages here. Valerie writes, we suggest to our participants that treatment needs adjusting and we want input from them on how to best get this done. Yes, I think that idea of input is really important too. There was another paper I came across kind of more recently. Actually, it was kind of more practice recommendations from people kind of thinking about, creating an advisory board of people, within the treatment setting, so the same way that that's kind of slowly being brought into sort of research and policy, but, you know, soliciting feedback from participants in treatment, you know, what's working, what's not, and kind of creating, you know, whether it's called an advisory board, but a way for people to kind of provide input and kind of meaningfully participate in the services that are offered. Wrapping up a little bit early, I'm happy to kind of stay and, you know, answer any questions, and give you a few moments here. So really appreciate your participation, and, you know, I'll definitely stick around if anybody has any questions or wants to ask anything else. And thank you to Clyde, who's facilitated the technology end of this.